Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Muhammad Ghassan Safi. I am a third year medical student in Sulaiman Rajihi colleges. In this video, I will give you a brief or a concise and comprehensive presentation about thyroid physiology. And I hope inshallah that this will help you to get a better understanding about this topic in the future. This presentation and other presentations will be like the first steps toward full student directed learning courses in the future for basic sciences. Okay, in this presentation we will look into the structure and definition of thyroid hormone, and also we will look into the synthesis and release. We will talk about HPT, or hypothalamus pituitary thyroid gland axis regulation, and we will talk about the physiological actions and effects of thyroid hormone. Let's start by the definition. Thyroid hormone is actually a peptide hormone, and it is a tyrosine-based hormone, or iodinide tyrosine-based hormone. So it is tyrosine-based compounds. Tyrosine is an amino acid, and it is characterized by the presence of benzene ring. Okay. It contains ether linkage. It contains ether linkages between, well, like here we have thyroxine or thyroid hormone. We have ether linkage here between two tyrosines. So this is a tyrosine and another one, and we will form ether linkages between those two. And of course, this is iodinide or iodinated. The functional or the two forms of thyroid hormone that possess we can say a physiological effect or actions are the T4 and T3. What we mean by numbers are those numbers represent the number of iodine in the structure of the hormone. So thyroxine T4 and also the T3 or triiodothyronine. Triiodothyronine will have 3 iodine without the 4th in the outer ring. It is although it is considered or it is a peptide hormone, unlike other peptide hormones, because usually peptide hormones work on plasma membrane receptors, but this peptide hormone actually works on intracellular receptors. It works through cytosol. Its receptors are present in the cytosol. They are once in the mitochondria and also in the nucleic acids. It is stored in thyroid follicles. What do we mean by this? Let's see the next slide. Okay, so this is how the thyroid gland looks like. We have cuboidal epithelial cells making a follicle. Okay, and this is another one. This is the like this, and also here. So, and also we have parafollicular cells in between. They are present like in here, in between. The follicular cells or the cuboidal epithelial cells are the ones responsible to synthesize the thyroid hormone. The parafollicular cells synthesize the calcitonin hormone. Okay, these are the two main hormones that are released by the thyroid gland. But the calcitonin will not be discussed in this presentation because physiologically it is more important to be discussed with the parathyroid hormone physiology. These follicular cells synthesize and release the thyroid hormone into the and store it in here. This space here we call the colloid. Colloid is like a pool. This is like a pool of proteins. It is mainly formed by the thyroglobulin protein. This is the thyroglobulin. Colloid is mainly formed, or it is like a condensation of thyroglobulin. What is thyroglobulin? Thyroglobulin is a glycoprotein, very long and large glycoprotein, which consists of many amino acids, and some of these are tyrosine residues. This is tyrosine residue, and this is where thyroid hormone can be formed. What will happen that iodine will come here and here also, and here we have ether linkage. So we will have like a thyroid T4 or T3 attached to the thyroglobulin. So thyroglobulin form like a storage protein, The appearance of the borders of the colloid is in normal versus hyperactive follicles. Here we see normal appearance of the colloid. These are the cuboidal epithelial cells or follicular cells, and we have here the colloid. This is the colloid. Here are the colloids. What's in the abnormal state, we can see that, or in normal state, we can see that the border between the colloid, here the border between the colloid and the epithelial cells are somewhat fused. They are fused together. There is no seen space in between. But in the abnormal state, we can clearly see the space between the colloid and the epithelial cells. And we can see also hypertrophied follicular cells. So this is called the scalloped appearance of the edges, and it is because of epithelial hyperactivity, which leads to active resorption of colloid. Active resorption will form these spaces. This is especially characteristic of Graves' disease. Okay, now we'll talk about the synthesis and release. Okay, let's see the steps. This is the follicular cell. This is a follicular cell. Okay, this is the basolateral membrane. This is the basolateral membrane here, and this is the apical membrane. Okay, so iodide, actually, this is in the negative charged. It is called iodide. Okay, iodide will enter the follicular cell from the blood by active transmission, or active or yeah, by active process. And what the transporter is called sodium iodide symporter. So you can say it is like secondary active transport. Okay, once the iodide enters the cell, it goes and out of the cell by the pentyrin transporter. Pentyrin transporter will exchange chloride to secrete iodide into the colloid. Here is the colloid space, you can say. So the first step will be iodide uptake, and then iodide release into the colloid. And the pentyrin, actually, when we talk about the pentyrin transporter, there is a congenital mutation. When there is congenital mutation in the pentyrin transporter, we call this pentyrin syndrome. Pentyrin syndrome, actually, there are two important manifestations, which are the hearing loss and the goiter, which will result in mild hypothyroidism. So because the pentyrin transporter is present in the cochlea, we will have, and the mutation happened in the gene responsible for the pentyrin transporter, we will have hearing loss. And the other place in the body that pentyrin transporter is present is the thyroid gland. So because the thyroid gland now isn't able to form quite numbers of thyroid hormone because of the iodine deficiency. This is not because of external iodine deficiency, it is because there is a mutation here and the iodine isn't transported into the colloid to complete the process. That will result in decreased thyroid hormone levels. This will result in increase of TSH synthesis, and TSH, which is the thyroid stimulating hormone, it is secreted from the pituitary, from the anterior pituitary, and it has hypertrophic effects on the thyroid gland, and that will result in goiter, which is enlargement of the thyroid gland. Okay, here also at the same time, or the thyroglobulin that we've talked about, which is the storage protein. Thyroglobulin, the storage protein for thyroid hormones. It is synthesized in the follicular cells and secreted into the colloid also, into the colloid. There are enzymes called peroxidases. What they do is that they oxidize the iodide. They oxidize the iodide to form iodine here. So this process, this step is very essential this conversion to iodine is very essential for the iodination process of the thyroglobulin. After that, actually there is here a clinical relevance. There is in some autoimmune diseases like the Hashimoto's thyroiditis, there will be autoantibodies against these peroxidases. Okay, so, and also when we want, or when we need to treat the thyrotoxicosis, for example, if a patient has thyrotoxicosis, which is the increased or hyperthyroidism, toxic hyperthyroidism, we will treat in by thiamide group, which will inhibit the peroxidases, So it seems, or it appears to be very essential for the function of, or for the formation of thyroid hormones. Okay, we also have so we can consider this the third step here, which is the secretion of thyroglobulin, and the iodination and coupling here we have the fourth step, iodination. Iodination, it is what we've shown before, that the tyrosine groups uh, that are attached to the thyroglobulin, there will be iodination. So this is iodination. And coupling, when we talk about coupling, we are talking about when we have conjugation here. So we are conjugating another iodinated benzyl group here to form either triiodothyronine or T4, which is the thyroxine. Okay, so this is the iodination and coupling. And also we will have what we call penocytosis. After the thyroglobulin is iodinated, there will be penocytosis or endocytosis into the cell once again. Okay, this is the fifth step, and will be transported in colloid droplet or vesicle. And inside this colloid droplet, we have proteases. These proteases, the function of these proteases is to cleave the, or to free, we can say, to cleave like this, to cleave the iodinated tyrosine residue from the thyroglobulin, and some will form T3 and others will form T4. Also, not that only, we have also DIT and MIT, which is mono iodinated thyrosine and diiodinated tyrosine, thyrosine. Those two doesn't have any physiological effect when are secreted. So the best way to use the best way to get rid of them is by, again, de-iodinize them and take the use of their iodine. So this process is called recycling. This process is very essential, actually. This process is very essential. And if someone has congenital defect and he has no deiodinizes, which we call the enzymes that make this process, are deiodinases. If they have deficiency in this, they might have also iodine deficiency, because the iodine that is not used in T3 and T4 will be lost also. So this process is very essential, and it is done by deiodinase type 1, and we will talk about the deiodinases types in a few minutes in the next slides. Now I would like to talk about T4 versus T3, which is the thyroxine versus the triiodothyronine. I will talk about these in the structure, secretion, their bound and free states, half-lives, peripheral deiodination, and biological activity. So first, starting with the structure, we've talked about the structure in the previous slides, and this is the difference. The only difference between thyroxine and triiodothyronine is the presence of this iodine in the outer ring. This is the outer ring here. Okay. So uh, what is secreted from the thyroid gland, 90% is secreted as T4 or thyroxine. So 90% is secreted and synthesized as T4. This resulted in that the total plasma concentration of T4 is 50-fold. It is 50-fold more than the T3. This is the total. Both are highly bound to plasma proteins, the thyroid binding globulin and the albumin and transthyretin. The most important one is the TBG or thyroid binding globulin, which is the most. They are mostly bound to this protein more than the others. T4 is bound is 99.98% is bound, and T3 is 99.5%. So this is the binding percentage for each. Okay, T4 is the most produced and synthesized, but still most of the biological actions are mediated by T3. How? How is that? Why we have most is produced as T4 and most of the biological actions are mediated by T3? So what is the answer here? Let's review. Total plasma concentration of T4 is 50-fold more than T3. However, free forms, which is not bound, unbound, free T4 plasma concentration is only 2-fold more than T3. So how? In the total it is 50 folds and here it's 2-fold only. You remember we talked about the binding percentage or the binding percentage of T4 and T3 to the plasma proteins. It is the difference in affinities. We've said that 99.98% is these proteins have affinity more than these plasma proteins have affinity more for T4 than T3. And this slight difference in affinities, what actually made this difference? What made it from 50-fold into 2-fold only? So this is one reason for being T3 having the most biological actions. The other reason is peripheral tissues convert most of the T4 that enters their cells into T3 by the action of deiodinases, type 1 enzymes. So although we have T4 concentration more, but actually peripheral tissues mostly or most of the T4 that reaches the peripheral tissues will be converted into T3 by the deiodinase type 1. And we will talk about the types in a few moments also. And the third reason is that thyroid receptors in body tissues has 10 folds more affinity for T3 than T4, and this results in 90% of the thyroid receptors are occupied by T3. 90% occupied by T3. So these are the three reasons that actually made T3 to made T3 to have the most biological action. T4 is deiodinated to T3 in the peripheral tissues, as we've talked about before. This process occurs by the enzyme 5,3-deiodinase. This, when we put this, actually we mean that it works in the outer ring. outer ring here. So when this enzyme will make the deiodination, that will take out the iodine groups from the outer ring. So this enzyme has two forms or two types. We have type 1. This type is actually present in the liver, in the kidneys, and in the thyroid. In the thyroid, as we've said, its main function is in the recycling. Uh, yes, and the type 2 is present in the pituitary, in the central nervous system, and the placenta. So type 1 is responsible for most of the T3 present in this circulation. Three quarters of T3 in the plasma is result from this enzyme, from the action of this enzyme, type 1. Type 2 actually is present in the pituitary, and it forms the basis for the negative feedback, for the HPT axis, negative feedback process. When the thyroid hormone is in the circulation in certain levels, that would the T4 and T3 will enter the pituitary gland, and T4 will be converted locally in the pituitary. So T4 enters the pituitary and is converted into T3 locally by this type 2 enzyme. So type 2 enzyme actually converts locally. Uh, and there is one clinical relevance here, is that in caloric restriction or starvation, uh, uh, yes, this will result in decreased T3 plasma levels. Why? Because the body will compensate by decreasing the BMR, the basic metabolic rate, or the energy expenditure of the body, by decreasing the production of the thyroid hormone. So the T3 levels in plasma will be down, but this will not affect the T3 levels or the thyroid hormone levels inside or intracellularly in the pituitary gland. So the levels inside the pituitary gland will not be affected, just to ensure that the regulation will be there no matter of the plasma levels. What is the importance of extensive plasma binding proteins? So extensive plasma proteins binding. What is the importance of this? The first one is this will make long half-lives. So the T4 half-life is 8 days. T4 is half-life is 8 days, and T3 is 24 hours. Also, this will result in large buffer pool. What do we mean by large buffer pool? This means that there is minute-to-minute regulation basis for both. So they are both tightly bound to plasma proteins, and whenever the free concentrations of these hormones is deficient or needing more, these plasma proteins will provide extra hormones. Also, the higher binding affinity for T4 makes it as a pro-hormone for T3, which means that it acts as a reserve for T3, regardless of its synthesis in the gland, for a defined period of time. So for a defined period of time, the regulation is by this binding and unbinding from the plasma proteins, regardless of the gland. Okay. we've talked or we've said that thyroid hormone works through intracellular receptors and mostly by nuclear receptors. And this is a picture shows us that it works on the nucleic acids. So there is thyroid response element which receives on the DNA or which receives the thyroid. And for the thyroid hormone to work or for the thyroid hormone to activate the thyroid receptors, it needs to form a dimer. It forms to form a dimer with retinoid X receptor. So dimerization is an essential process for the activation of thyroid receptors. Here, these are the clinical values for T4 and T3. We've talked about that physiologically, but clinically there will be sometimes differences, and this is what we actually need to remember as a clinician. We need to remember these values. So we can see here that the total hormone is 8 microgram per deciliter for T4, and for T3 it is 0.14. So we can see here that it is really 50-fold more than the T3, the concentration. Also, we can see here differences in the half-lives. In the physiological part, we said that it is 24 hours, and on the clinical level, it is 2 days. And here it is 20% only from the thyroid, and the other 80% is from the conversion, peripheral conversion of T4 into T3. So the hypothalamic pituitary thyroid axis. We will talk about the regulation in a brief manner right now. So this is the hypothalamus here. We have the hypothalamus. We have the pituitary glands, the anterior and posterior, and we have the hypophyseal pituitary circulation or portal system. And so here we have the hypothalamus. Hypothalamus synthesizes and secretes TRH, which is the thyrotropin releasing hormone. Thyrotropin releasing hormone. It is formed in the arcuate nucleus in the hypothalamus, okay, and goes all the way into the anterior pituitary to stimulate the synthesis and release of TSH, which is the thyroid stimulating hormone or thyrotropin. Thyroid stimulating hormone formed by the anterior pituitary will go and stimulate the thyroid gland to secrete the thyroid hormones. So there is, we can see here that the thyroid hormones have negative feedback on the anterior pituitary and the hypothalamus, while the TSH has negative feedback onto the hypothalamus also. The thyrotropin releasing hormone. So yes, we have it is a tetrapeptide, thyrotropin releasing hormone. It's a tetrapeptide. It is formed by the arcuate nucleus and the median eminence of the hypothalamus, and it works through G protein coupled receptors through phospholipase C pathway. These receptors are in the thyrotropes. The thyrotropes cells in the anterior pituitary. These cells will form the TSH. So it has receptors in the thyrotropes cells in the anterior pituitary. They are G protein coupled receptors. Its action is to increase the release and the synthesis of TSH. And actually the TSH is stored in these cells in secretory vesicles. So it stimulates the release and synthesis of TSH. The thyroid-stimulating hormone, it is a glycoprotein. Thyroid drops in the anterior pituitary gland and formed from alpha and beta chains. So it is formed by alpha and beta chains. Beta chain is characteristic of this hormone. Alpha chain is present in the LH, luteinizing hormone, and FSH also, but not beta chain. Beta chain is a characteristic for the thyroid stimulating hormone. Yes, and here the TSH actions, the thyroid stimulating hormone, what it does that it stimulates approximately all the steps that we've talked about when we've discussed the synthesis and release of thyroid hormone. It increases the iodine production here, or the iodine uptake, the iodination process, the coupling process or conjugation process, also the endocytosis or pinocytosis here, the proteolysis in here, and the secretion of T3 and T4 into the circulation. And one other also is the hyperplasia. So whenever, it is important for the growth of the thyroid gland, and whenever we have TSH levels or high TSH levels chronically, we will have goiter or increased or enlargement of the thyroid gland. So the T3 negative feedback. Negative feedback is mediated by type 2 deiodinase or outer ring deiodinase enzyme. We've talked about that. It is the type 2 that is present in the pituitary and is responsible for local conversion of T4 into T3. T3 feedback is through direct and indirect. Direct, it decreases the synthesis of TSH hormone. So whenever the levels are at certain stage of T3 will directly decrease the synthesis of TSH hormone. The indirect way is to decrease the thyrotroph sensitivity to TRH. So it will decrease the receptors for TRH, which usually stimulate the synthesis of TSH. So this is the way. We have directly affecting the TSH synthesis and indirectly affecting TSH synthesis by decreasing the sensitivity to TRH that comes from the hypothalamus. Now we'll talk about the thyroid hormone actions. Okay, actually the thyroid hormone, what it does that it increases the basal metabolic rate of the body, meaning that its only or its purpose is to increase the energy consumption for all the body tissues, all tissues in the body, the oxygen consumption and the energy expenditure, which will result in the end into thermogenesis or heat production. So in order to do that, it stimulates futile cycles of metabolism. What do we mean by that? That like purposeless cycles, purposeless cycles of metabolism. We can see this clearly that, for example, high levels of thyroid hormone will increase the gluconeogenesis, will increase the synthesis of proteins and proteolysis also. So it increases the catabolism and anabolism of the in approximately all tissues of the body. So in order to increase the basic metabolic rate and heat production. So if you want to look at its effect on like carbohydrate level, protein level, lipid level. For example, in the carbohydrate metabolism, it will increase the gluconeogenesis and the glycogenolysis. But in the end, we will have normal serum glucose. How is that? How we are increasing the gluconeogenesis and we have normal glucose level? Because at the same time, the beta cells in the pancreas will increase its activity and will increase the insulin level. So we will have also uh, we will have also high levels of insulin. High levels of insulin. Here in the protein metabolism is again the synthesis and proteolysis, but the proteolysis will predominate, and if chronic and very high, this will result in muscle wasting and fatigue. Lipid metabolism, lipogenesis and lipolysis also, but in the end actually the lipolysis will be more and we will have weight loss. We will have weight loss in the end. We will have weight loss in the chronic stage. Autonomic nervous system, it will increase for thyroid hormones, increase the activity of the sympathetic autonomic nervous system. How is that? Not by occupying the beta adenoreceptors, no, but by increasing the expression of beta adenoreceptors, meaning increase the sensitivity to catecholamines, which will result in increased sympathetic activity of the body. Also, it is important for CNS development, for growth, and we will see that in a few minutes. Cardiovascular, the output, the strength, rate, flow. So these are the effects of, and of course it is slow mediated because it is by gene transcription. So it is slowly initiated and slowly regulated. Okay, hyper versus hypo states. In the hypothyroidism and hyperthyroidism, for the PMR we know this will increase and the hypo will decrease. Muscle wasting in the hyper, fatigue, and here muscle sluggishness in the hypo. Difficulty to sleep in the hyper, here the opposite, extreme somnolence. Rapid and forceful beats, slow, which are the opposite to each other. Also we have weight loss, here weight gain, diarrhea in the hyper and hypo, constipation, and we have exophthalmos in the hyper and increased sweating and heat intolerance, and this is very important symptoms, heat intolerance and sweating in hyperthyroidism patients. Okay, we have whenever we have congenital hypothyroidism, this is a very dangerous thing. Hypothyroidism coming from birth, it is very dangerous. It will lead to severe mental retardation if not corrected rapidly and fastly, because it appears that the thyroid hormone is very essential for mental development in the first few years of life. So this may lead, if not corrected, to cretinism. Cretinism is a syndrome characterized by profound mental retardation, short stature, delay in motor development, and coarse hair. So early screening for newborns is essential, and this is what the neonatal units are doing in those days. That is essential to test the newborn for its thyroid function. And the cretinism actually, when it manifests or when it's discovered, it means that that we've discovered the hypothyroidism in the child lately, because we have so short stature, coarse hair, motor development, delay in motor development. So it is a syndrome. But in the early days, or in the early days, we have mainly the mental retardation that is affected. This is late. This is late. And this is a graph shows you that for the hypothyroidism patient or thyroid deficient child, we have the mental age is at 6, the chronological age, it should be at 6, but here we have it is 1.5 years or something like that. So it is severe mental retardation. Okay, how does TH affect growth? In rats, it's found that thyroid hormone induces GS secretion, but in humans, there was no response element for TH. So mechanism is not yet fully known, although it is very essential for growth. So what is observed that in hypostates, we have delay in ossification for the epiphyseal plates, and for delay in ossification in the ossification center, I mean, and growth hormone resistance. So the receptors for growth hormone will become resistant for growth hormone because of hypothyroidism. Okay, fundamental role in growth. We've talked about its fundamental role in development, mental development, but in growth also, it's very essential for skeletal growth. And if hypothyroidism developed after birth, not congenital, so after birth, the child developed hypothyroidism, dwarfism might occur. Dwarfism means that the dwarfism is short stature and short in development. It occurs in children, and there's something called catch-up therapy. The earlier we catch the child, the most improved outcome will occur. And actually, we observe that through something called growth curves, which are essential for pediatric population screening and monitoring. Okay, what is the effect of hyperthyroidism on growth? We've talked about hypo. Okay, what about hyper? Okay, the child will become taller at earlier age, mature more rapidly, but in the end, he might be shorter. How is that? How is that? Because it becomes taller at earlier age and much more rapidly. This means that its epiphyseal plate or epiphyseal plate, growth plate, will fuse more earlier. So at the end, he might be shorter than the others because he had he has become taller at earlier age, but at the end, the other children will become taller when the epiphyseal plates is fused in this child. This was the presentation about thyroid physiology. I hope it helped you and it was comprehensive and understandable. And these are the references: boron physiology, Guyton, and Robbins at Cotram for pathology. Thank you very much for your interest.